Hi everyone. So today we're going to go through the clinical scenario on hypernatraemia that we had last week. We had a 5-day-old neonate who was admitted to our AO1 ward after being referred to us from Matero First Level Hospital. And this baby had a 2-day history of being irritable and also body hotness. This is mom's first baby, and baby had been born at term after 27 hours of labor with a birth weight of 4 kilograms and an upto of 9. Apart from the fact that mom had some fever during the delivery, the antenatal period had been uneventful. The fever had been discounted as inconsequential by the attending health worker. So in addition, mom tells us that even right from the start, she'd been having trouble with establishing breastfeeding, but in particular, she noted that even the baby's eagerness to suck had been diminished starting from 2 days prior to admission. And then she noticed that the baby developed body hotness. And then in the last 24 hours, she's only changed one wet diaper for the baby. On examination, we found that this baby was lethargic and had cold peripheries. Vitals included a capillary return time of 6 seconds, a respiratory rate of 78, which is increased, and the pulse rate of 180, which is also increased. The admission birth weight was 2.8. So remember, the birth weight of this baby was 4 kilograms. So within 4 days, this baby had lost 1.2 kilograms of weight. And then the random blood sugar on admission was found to be normal at 8.2 millimoles per liter. Within about 5 minutes, the lab had been able to give us results. And so we had an admission hemoglobin of 14, a raised white cell count of 20, a normal platelet count, a neutrophil percentage of 90%, a raised procalcitonin of 15, a C-reactive protein of 18, the urea was 16, and the creatinine was equally raised at 279. The serum sodium was markedly raised at 185, and the potassium was mildly raised at 5.7 millimoles per liter. So the questions were that firstly, we were required to construct a problem list for this patient, and the second was that we were to come up with a treatment plan for this patient. So the first identifiable problem is the fact that this patient has early onset neonatal sepsis. So the baby had fever, had poor feeding, had lethargy. And the lab told us that the acute reactant protein procalcitonin was raised. In this patient, it was markedly raised at 15. So a procalcitonin greater than 0.5 is highly predictive of bacterial sepsis. The baby also had risk factors for sepsis. The fact that mom had intrapartum fever also would be a risk factor for sepsis. So because the onset of this sepsis was before 7 days of life in a term neonate, this would be called early onset neonatal sepsis. The definition varies for patients admitted to the NICU and for preterm babies. You can look at the reference documents. Mom also told us that she had been having trouble establishing breastfeeding even before this baby got sick to the point of being admitted to the hospital. Factors that could contribute to this: she's a first-time mom, so she's inexperienced, so that could have made it difficult for her to establish breastfeeding. And then she also mentioned that labor took 27 hours, so the labor was prolonged. She didn't go into details, or we are not provided with that information. She may have had to have an episiotomy. It was quite a big baby, 4 kilos. And so all these factors would add to psychosocial stress as well as physical discomfort for mom and would make it difficult for her to establish breastfeeding. Then we also have neonatal factors. The fact that this baby, starting from about 2 days of life, had lost the ability to suck well, probably because of the onset of the sepsis. So all these factors in this particular patient could have contributed to lactation failure. There are other factors that may lead to lactation failure that we need to look up, so that as we assess neonates that are coming in, we'll be able to pick these up and probably design systems and ways of preventing the occurrence of lactation failure. As I said, this baby was admitted with a weight of 2.8 kilograms, and yet just 4 days prior to admission, the baby had weighed 4 kilograms at birth. So this baby lost 1.2 kilograms in just 4 days. They lost 30% of their birth weight. This is excessive. We know that there's a physiological loss of weight in neonates of between about 6 to 10%, but this is often regained by about 10 to 14 days of life. So because of this excessive weight loss, we feel that this patient has severe dehydration. The fourth identifiable problem in this patient is this plasma sodium of 185. This would be classified as severe hypernatremia. So generally speaking, when we talk about hypernatremia, potential causes could be, one, the fact that this patient has actually gained sodium molecules. Like, for example, if you're giving a patient an inappropriately high sodium containing IV fluid, like for example, in neonates, they are unable to handle high sodium loads. Their kidneys are not able to get rid of the extra sodium. So if you give normal saline to a neonate like that, you could cause hypernatremia. Patients that have received hypertonic saline, perhaps to treat cerebral edema or to treat hypernatremia, you could overshoot and cause hypernatremia. Patients that are receiving bicarbonate to treat acidosis or as part of resuscitation could end up with a gain of sodium hypernatremia. Or patients or babies in particular receiving poorly reconstituted milk, concentrated milk, are in danger of hypernatremia. And finally, those babies with acute gastroenteritis who are receiving homemade poorly reconstituted ORS are also at risk of gain of sodium hypernatremia. So clearly, none of these factors are operational in our patient. So therefore, we don't think the baby has had a net gain of sodium. On the other hand, a patient could develop hypernatremia because they've lost water, more water than they've lost sodium. Our patient has lost 30% of their birth weight. So it's quite suggestive of the fact that probably the mechanism by which this baby developed hypernatremia is water loss. So where could this baby have lost their water from? There are two options. One is that they could have had excessive loss of water through the kidneys, or they could have had excessive loss of water from sites other than the kidney. So when we talk about patients losing water through the kidney, we expect them to be passing large quantities of urine. Clearly, our patient did not have polyuria. So therefore, we do not think that it's because they lost water through the kidneys. For patients that have this mechanism of loss of water, possible causes could be, for example, osmotic, those patients that are hyperglycemic, those with a very high urea, those who have received mannitol. Others are patients that have concentrating defects, so they have damage to the medullary part of the kidneys, so they are unable to concentrate their urine. Patients with like sickle cell, obstructive uropathy, or other pathology in the interstitium. And then also patients with diabetes insipidus, either central or nephrogenic. So because our patient does not seem to have had polyuria according to the history that we've been given, it's very unlikely that the renal loss is through the kidneys. So we then tend to extrarenal sources of water loss. One is GIT losses, so patients that are vomiting, patients that have diarrhea. So from the history given, mom says there's no diarrhea, no vomiting in this baby, so it's unlikely to be due to GIT losses. Skin losses may have contributed to the development of hypernatremia in this patient. So the baby has fever, so that increases loss of water through the skin. So certainly that could have contributed. This baby's respiratory rate is increased, so hyperventilating patients also have increased loss of water through that route. So that could have been a contributing factor. And then patients with reduced ability to take in water, so unconscious patients, babies, neonates who are unable to say when they feel thirsty. So most likely that could be the major mechanism that could account for water loss that led to the development of hypernatremia. The other factor also is the fact that this baby on day 2 then had this onset of sepsis that even reduced the ability for the neonate to suck. So in this case, the hypernatremia most likely is due to loss of water. So the other problems, not necessarily presented in order of priority, are shock, acute kidney injury, and hyperkalemia. So this patient had a serum potassium of 5.7, above normal by 0.2 millimoles per liter. So that's mild hyperkalemia. It's unlikely that they will suffer cardiotoxicity from this level of hyperkalemia, but just to be certain, we can connect the patient to an ECG lead and check for signs of cardiac toxicity. So the usual prolongation of the PR interval, the TOTI waves or late phase would be like a prolonged QRS complex. So if those are not present, then the patient is not at risk of cardiac toxicity. For the acute kidney injury, this patient has poor urine output, has a raised creatinine of 267. So I think the predominant mechanism that's at play here is reduced renal perfusion from loss of 30% of the body water. And then secondly, the fact that this patient has sepsis with dilatation of the peripheral vasculature. So that would be the predominant mechanism causing acute kidney injury. But also in addition, the sepsis could cause direct injury to the kidney. The last problem, though not by any means the least important, is the shock. So this baby had a capillary refill of 6 seconds, had cold peripheries, so was clearly in shock, and the shock is both septic as well as hypovolemic. This baby had a procalcitonin of 15, markedly raised. This baby has lost 30% of their body weight. So in summary, the problem list is that we have a 4-day-old neonate with early onset sepsis who also has septic shock, has lactation failure that probably contributed to the development of a hypernatremic dehydration, and this patient also has an aspect of hypovolemic shock. Patient has acute kidney injury, which is associated with mild hyperkalemia. Our strategy for treatment of this patient will have 3 phases: the emergency management of the patient and then monitoring of treatment response. Because I will not come back to the subsequent care, I'll just mention quickly that it's important in this case to provide counseling to mom in terms of the severity of illness of the child, to talk to her about the risks to the baby and the prognosis. And then it's also important to help her by introducing her subsequently, once the baby is better, to a breastfeeding counselor who will work with her to re-establish lactation. And if possible, to give her medications to help her to increase production of milk. So we'll move on to the emergency management. Okay, so for the emergency management, as usual, we're going to manage the airway, the breathing, the circulation. So from the scenario, there's no particular mention that there was any problem with the airway, but we'll check the airway to make sure there are no excessive secretions. If those are present, we're going to suction. We'll position the baby's head in the neutral position so that the airway remains patent. And then for the breathing, we're going to give high flow oxygen and make sure that the baby is saturating well. Assess the work of breathing and use the usual guidelines to decide if this patient needs intubation and possible ventilation. And then we'll manage the circulation. So according to the scenario, the patient's capillary refill time is very prolonged. At 6 seconds, the peripheries are cold. And so obviously this patient is peripherally shut down. They have lost more than 30% of their birth weight. So they are severely dehydrated as well. So according to the surviving sepsis guidelines, we're going to use normal saline boluses using aliquots of 20 mils per kg for each bolus, and we're allowed to go up to 3 boluses in a center where you know that you have ventilatory support. That's because one of the risks of giving these boluses, and particularly as you begin to approach 40 mils per kg of fluid given, is the fact that this patient could develop pulmonary edema because of the sepsis and the leaky capillaries, but also particularly for our patient who mom said has poor urine output, there's a real risk of possible development of pulmonary edema. So in a situation where you do not have ventilatory support, it might be prudent to restrict yourself to a maximum of 2 boluses, which is 40 mils per kg of fluid. And then in addition, this patient has septic shock, so fluid resuscitation alone is unlikely to restore peripheral perfusion. So therefore, early institution of use of vasopressors is advisable. So according to the guidelines, the vasopressor of choice is no adrenaline for septic shock, but at our center that is not usually available. So then the guidelines go on to tell us that we can actually use just adrenaline, and then if that is not available, dopamine is acceptable. The problem with dopamine is that it is more arrhythmogenic than adrenaline, and particularly in this patient with renal failure, hyperkalemia, hypernatraemia would not be our first choice. The guidelines then go on to tell us that we need to make sure that these antibiotics that we give this patient are administered within the first hour. So you choose appropriate antibiotics based on what the potential pathogens for your patient are. So for our patient, there's a risk of both gram-positive, gram-negative bacteria. So we'll choose broad-spectrum antibiotic. We use cefotaxime. They've been at home for more than 72 hours. So we'll also add on some cloxacillin. So then we can now talk about the management of the hypernatremic dehydration. So hypernatremic dehydration is a bit different from normotonic dehydration in the sense that the body puts in place mechanisms to protect the brain cells against dehydration. Because remember, when the extracellular space initially becomes hypertonic, water will move by osmosis from brain cells to the extracellular space, and the brain cells will shrink. So there are mechanisms in place to try and defend the volume of the brain cells. And these mechanisms include movement of sodium, chloride, and other organic molecules into the inside of the brain cells. These are osmotically active and induce a reverse movement of water back into the brain cells in a bid to try and restore the cell volume. It takes about 24 to 48 hours for this mechanism to come into place. So what happens when we rapidly correct the hypernatremia is that the extravascular or extracellular space will become suddenly normotonic, whereas the intracellular space will not have had enough time to clear these extra organic osmos, the extra electrolytes that were mobilized into the cell. And so what will result is that we'll get a movement again by osmosis from the relatively hypotonic extracellular space into the intracellular space, and this will cause brain cell swelling, which would result into cerebral edema manifested as reducing levels of consciousness, seizures, and eventually would result into herniation and death for the patient. So early studies that were done more than 50 years ago actually showed that a safe rate of correction for the sodium would be a reduction in the sodium of only about 10 to 12 millimole reduction per day, which translates into roughly 0.5 millimole per hour drop in the sodium. The second principle governing the replacement of the fluid that this patient has lost is the fact that we need to make sure that the solution that we're giving to this patient contains less sodium than the sodium content of the urine, because if we don't do that, what will happen is, in actual fact, that the baby's sodium will actually either stay the same or even go higher. So unfortunately, at our center, we're not able to determine urine sodium. So as a general guide, we are going to be giving hypotonic fluids in order to correct this hypernatremia. The treatment of hypernatremia has two stages: the emergency management phase and the replacement of the deficit phase. We've already discussed the emergency management phase under the ABC. This would involve treatment of shock, and we said already that we would be using normal saline boluses and vasopressors if indicated. But it's important to remember here that if you know at the time that you're treating the shock, if you already know that the patient has hypernatremia, it might be prudent to give the boluses in smaller aliquots of 10 mils per kg at a go. You would still give the same total amount, but just slower. And this is because patients with, for example, severe hypernatremia may still be at risk of developing cerebral edema when you use normal saline. This is because the normal saline is still hypotonic relative to the very high sodium levels that some of these patients come in with. So for example, the patient in this scenario has a sodium of 185. So the normal saline is hypotonic to that. So that's why you would give smaller aliquots at a go. But otherwise, the emergency management remains the same. We move on to the replacement phase. So the replacement phase involves the recognition of what the fluid requirements for the patient are. So the fluid requirements for the patient will include the fluids that they have lost, the fluid loss that has resulted into the hypernatremia, and then their ongoing fluid needs. We know that patients have maintenance fluid requirements because they lose water through urine, and then we have insensible loss of water through the skin, through breathing. So we have to figure out what the maintenance requirements for this baby are. And then some patients who come in with hypernatremia may also have ongoing fluid losses, like for example, if they have an active NG tube, or if they have vomiting, or if they have diarrhea. So that also has to be taken into account. So how do we determine what the total fluid deficit is for the patient? The fluid loss that has led to them developing hypernatremia. That's what we'll start off discussing. So for the total fluid deficit, we use the normal formula, which is the percentage dehydration multiplied by 10 multiplied by the weight of the patient in kilograms. How do you decide percentage dehydration? If you are lucky and know what the pre-morbid weight of the patient is, it's easy. Like we did earlier, we calculated that this patient had lost 30% of their body weight. In the absence of a knowledge of the pre-morbid weight, we use clinical features of the patient to decide whether the patient is mildly, moderately, or severely dehydrated. And as you know, mild dehydration is roughly equivalent to 5% or less of dehydration. Moderate dehydration is equivalent to between 5 to 10% dehydration. More than 10% would be considered as severe dehydration. So again, for a patient, we know what the percentage of dehydration is. It's 30% multiplied by 10, multiplied by their pre-morbid weight of 4 kilograms gives us a total fluid deficit of 1,200. So for this baby to develop their hypernatraemia, they actually lost 1,200 mils of fluid. So we then look a little bit more at the composition of this total fluid loss. So the total fluid loss has two components. The first is loss of just water. These patients, remember we said, have lost more water than they have lost electrolytes. So they have the free water loss. But it's important to remember that they're also losing water in combination with electrolytes. They have a normotonic fluid loss. So out of this total fluid deficit that we found of 1,200, how do we know how much of that is free water? So we'll use the normal formula that is circulating, that we all use, the free water deficit formula, to calculate and find out how much of this total fluid deficit is free water. I'm just about to display the formula that all of you know. So this is the formula, and it's based on the fact that if you have a patient with an original, well filled up body, you can calculate their total body water, assuming that their body consists of about 60% water. So if you know their body weight, you can calculate their total body water. So if this patient suffers some kind of dehydration and develop hypernatraemia, they will also have a drop in the weight, and you can, based on the ratios of the new sodium and the old sodium, you can calculate the composition of their body water. And so then once that is done, you can subtract the new body water from the old body water. And that's all this formula is showing us. So for a patient, we know that they have a weight of 4 kilograms, and feeding all those figures into the formula, we end up with 0.66 liters as the free water deficit. So the formula gives a result in liters, so you have to convert it to 660 mils by multiplying the answer by 1,000. Just a note here, you find that sometimes literature then will show that neonates, the percentage of their body that is made up of water is higher at 0.7, and for the preemies, that's even higher at 0.8. And if you want, you can use those, but by and large, I prefer to use 0.6 for everybody, because these figures are just estimates and work perhaps in a bigger population and at an individual level, depending on how much fat a particular individual has, the 0.7 or 0.8 may not be strictly accurate. So I tend to, just to make life easy, use 0.6 for everybody. So in short, our free water loss is then 660. So then we try and figure out how much of this fluid loss is normotonic fluid loss. I take you back to the formula, which told us that the total fluid deficit for this patient is that they have some free water loss plus normotonic fluid loss. So if we switch around the formula, we'll be able to see that the normotonic fluid loss is equal to the total fluid deficit, which we know is 1,200, minus the free water loss, which is what we have just calculated. And so this patient has lost 540 mils of normotonic fluid. Then we turn to maintenance requirements. We'll use the usual chart, which tells us that for the first 10 kilograms, the maintenance requirements are 100 mils per kg. And then for anything additional up to 20 kilograms, we use 50 mils per kg. and then for anything above 20 kilograms, we'll use 20 mils per kg. So using that information then, our patient is 4 kilograms, that's within the first kilogram. So 4 multiplied by 100 gives us a maintenance requirement of 400 mils per kg per day. Now, before we proceed, remember I said that because of the adaptive mechanisms that have happened in the brain cells, you do not want to drop the sodium too quickly. So this patient of ours has a sodium of 185, and we want to make sure that we do not drop the sodium by more than 10 millimoles per day. So if we are to get to 145, it means that we have to drop almost 40 millimoles. And if we divide that by 10, we see that in order for us to safely drop from 185 to 145 without exceeding that limit of 10 millimoles per day, we would have to do it over 4 days. So knowing that the rehydration process will take us 4 days, we would then decide that the maintenance requirements for this patient over these 4 days is the 4 days multiplied by the maintenance fluid requirements for each day, which we just calculated up there, the 400 mils per day. And so the maintenance requirements over the next 4 days, over which we will try to correct the hypernatremia, will be 1,600. So let's total up what we've said about the fluid requirements over these 4 days. So we've said that the free water loss for this patient is 660. The normotonic water loss is 540. The maintenance fluid requirements over the next 4 days will be 1,600. There are no ongoing losses. And then remember, we used fluids to treat the shock in this patient. We just gave one bolus, which is 20 mils per kg. That's 80. So we must remember to subtract that from the total fluid requirements. So if we add up everything, it means that we need to give this neonate 2,720 mils of fluid over the next 4 days. So if we want to break that down into the number of mils per day, we would be delivering 680 mils of fluid per day. Then we need to remember that this patient also has electrolyte requirements. So for the free water, there are no electrolytes, obviously. That's why it's free water. But then remember, we said that this patient has lost normotonic water. So if 1 liter of normal saline contains 154 millimoles, how much or how many millimoles of sodium will be present in 540 mils of our normotonic water loss? And if you do the calculation, you come up with 83. So it means that when our patient lost 540 mils of the normotonic water, they also lost 83 millimoles of sodium. And so those have to be replaced. And then this patient, we've decided, will require 1,600 mils of maintenance fluids. Patients generally, children, infants, have a sodium requirement per day of between 2 to 3 millimoles per kg. And so bearing that in mind therefore, if we calculate, it comes to 32. So our patient has a maintenance requirement of sodium of 32 over the coming 4 days. There are no ongoing fluid losses, so there will be no sodium calculation for that part. And then we gave our patient 80 mils of normal saline as part of resuscitation. So 80 mils of normal saline contains 13 millimoles of sodium, and so we'll subtract those 13 millimoles from the total sodium calculation. And once you total up all those requirements, you come to 102 millimoles of sodium that will need to be given over a 4-day period. So the requirement for sodium per day would be 26 millimoles. So what type of fluids do we use for this correction? We've seen that the daily requirement for this neonate is 680 mils of water and the electrolyte requirement is 26 millimoles. The equivalent of this is saying that if I have a 1 liter bag, there will be 38 millimoles of sodium. And then let's just look at all the different types of crystalloids that are available commercially, and then we'll try and pick out which one would have 30 millimoles of sodium in 1000 mils of water. So this is the composition of commonly used crystalloids, and I've highlighted in red that 0.18% or quarter normal saline has a composition there of 31 millimoles. That's the closest. If you look across that row, that's the closest to what the electrolyte requirements are for this patient. So therefore, we're going to deliver 680 mils of quarter normal saline per day to this baby in order to be able to correct the sodium within the next 4 days. Okay, and we need to monitor the serum sodium every 4 hours so that we make sure that the drop in sodium stays less than 0.5 millimoles per liter per hour. Unfortunately, life is not as simple as that. As Einstein said, everything should be made as simple as possible, but not simpler. So one cannot just do all these calculations that we have done and then walk away from the patient, because there are various clinical situations that alter the way that this calculation would work in a patient. So for example, in patients who have kidney failure and have reduced urine output, like our patient, the calculated volumes may be too much. In patients who have hyperglycemia, we know that when patients get hypernatraemia, it reduces the release of insulin. And so up to 2/3 of patients presenting with hypernatremic dehydration may actually also have significant hyperglycemia. So the management of these patients becomes tricky because they have two osmotically active substances, the glucose as well as the sodium. So one has to be very careful in managing the situation. By and large, rehydration would be expected to control the hyperglycemia, and insulin is rarely necessary. And then also just to remember that the concept of the maintenance fluid varies from patient to patient. So we have the formula for maintenance, which we all accept, but the actual value may be affected by things like hyperventilation in a patient, fever with increased losses, or indeed may be affected by things like, as I've said already, reduced urine output, patients who are anuric. So 2/3 of maintenance requirements are accounted for by urine output. So in a patient who is not passing urine, you can see how the maintenance fluid is reduced. So all those factors have to be taken into account as we continue to look after these patients. And then there are actually studies or papers that have been produced that bear witness to the fact that these are just estimates, and therefore one cannot rely 100%. They are not foolproof. So I'm just about to show those two papers. These two are examples of papers that discuss the fact that the various equations don't always predict the changes in sodium accurately. The first one measured the utility and accuracy of 4 equations in predicting sodium levels in dysnatremic patients. And the second one urges us to curb our enthusiasm for all these various formulas as a way of fixing serum sodium problems. And the conclusion really is the fact that human beings are not closed systems, and therefore there are various factors that could affect the way that these formula work. And then many of these equations were actually derived in populations different from our own and many years ago, so may not work exactly as predicted in our population. So some practical tips that I have found useful in managing children with hypernatremic dehydration. So the first is to remember that what kills patients is not dehydration but shock. So it's important to correct the shock quickly. Don't delay vasopressors if they are indicated. And then because we have problems sometimes in getting the 4-hourly sodiums that are required for us to safely deliver replacement fluid, I often just restrict the fluids to just replacing maintenance fluids and then the free water deficit. And often this will be done between 48 to 72 hours. And then if there's no contraindication, it's safer to use the enteral route. But for all cases of severe hypernatremia, that is anyone with a sodium above 160, initial rehydration should be intravenous. And remember to keep the patient nil by mouth so that their intake in terms of fluids can be carefully monitored. By and large, quarter normal saline is preferable to half normal saline, particularly in neonates, because remember, neonates have a reduced capacity to handle a sodium load. So if we give half normal saline to a neonate, we may actually notice that the serum sodium is not changing, or it actually starts going up. And then to ensure that the drop in sodium is not more than 10 millimoles per day. And the only way of ensuring this is by testing frequently so that fluid infusion can be adjusted according to the actual changes. And then most times, hyperglycemia resolves with just the rehydration. If there's no improvement in hyperglycemia and we have to use insulin, this has to be done very judiciously, preferably involve a senior before starting insulin, because what will happen is that you will drop the glucose too quickly and this will lead to a patient developing cerebral edema. So the most important thing is to do repeated measurement of serum sodium levels and frequent and meticulous clinical assessments of patients so that we can adequately adjust fluid therapy. It is only in this way that we'll be able to safely manage hypernatremic dehydration in patients. These are some of the references that you might find useful to read up on your own. And then I added an addendum for those of you who've been asking about various formula that are discussed in various literature. So this is a table showing all the different types of formula that people use to try and figure out what the free water is and so on. And in particular, many have been asking about the Adrogoue-Madias equation, which I'm going to show next. So this is the Adrogoue-Madias formula, and essentially the difference between the one that we used earlier and this one is that with this equation you can feed in the amount of sodium and potassium that are present in your fluid of choice that you want to use, and it will be able to predict that if you give 1 liter of that fluid, the expected change in sodium would be, it will give you the expected change in sodium, and so therefore then you would be able to decide how much of that fluid to give. But if you go back to the papers that I talked about, one of the equations that were assessed was still this Adrogoue-Madias formula, and it was still found that in some cases it was not predictive of the actual changes. And then also the other thing with this Adrogoue-Madias formula is the fact that it does not take into account maintenance requirements, ongoing requirements of the patient. So again, I would recommend that we give our patients maintenance requirements, give them the free water as calculated above, and any ongoing losses, but most importantly, monitor the changes in sodium by doing repeated serum sodium levels. Thank you.